Today's episode is brought to you by DAX Copilot from Microsoft. DAX Copilot is your AI assistant for automating clinical documentation and just being more efficient, reducing administrative burden, all that stuff that makes us feel overwhelmed and burnt out. To learn more about how DAX Copilot can help improve healthcare experiences for both you and your patients, stick around after the episode or visit aka.ms/knockknockhi. That's aka.ms/knockknockhi.
Knock, knock, hi.
Knock, knock, hi. Hello, everybody. Welcome to Knock, Knock, I, with me, your host, Dr. Glaucomflecken. If I look a little disheveled, I need a haircut. All right, for those of you watching on YouTube, I'm not looking my best right now. I just got done with a day of clinic, literally like 20 minutes ago. I was raring to go. I wanted to get home, knock out this recording, because I need to have some time with the kids to play later. So anyway, we're just gonna get this done. I'm excited because a lot has happened in the last week since I last recorded an episode of Knock Knock I, and part of the reason why I am so haggard looking is, number one, I need a haircut. It's bad. It's getting real bad. It's like, before I would say, even like 5 years ago, or when I started making TikToks, actually, when I started making videos, like my hair would get long and it would still like look kind of good, like luscious, if that's a way you describe hair. But now it's like I'm just showing the early signs of hair thinning. It's still, I still got a lot of hair, but there I can tell. I know in the back you can't even see it. It's getting a little thin. My kids are making fun of me. It's coming up a little bit on the temples, and so when my hair gets long, it looks worse. It doesn't look good anymore when it gets long. It just looks like I have just do not have adequate personal hygiene. So anyway, definitely need a haircut. Tomorrow I'm getting a haircut. But also, I just got back from our live show trip to Iowa. I took the whole family, and part of the reason I'm tired is during that trip, would you believe me if I said that I went willingly to a hospital to walk around, to go on rounds, to talk with people? I, an ophthalmologist, on a Sunday, went into a hospital. I did, and it was actually my idea too. All right, let me explain, because I know you're probably thinking, "You poor guy, who made you do this?" And we all know the second biggest fear among ophthalmologists is hospitals, because they're always open. We know this, like even on the weekend and nighttime. Hospitals, they never close. This scares us as ophthalmologists. So, and that's the first greatest fear. The greatest fear of the first grade. The greatest. I'm going to be a little all over the place today. The greatest fear is responding to in-flight medical emergencies. I've talked about this. And the third biggest fear for ophthalmologists, ICU consults. But number two is the hospital. And let me just explain to you how I ended up at the hospital. So I went to Iowa, my old stomping grounds, where I did my residency training. And we were so excited. This show, we rented a theater in downtown Iowa City. It's not that big, but it's big enough. It's a college town, right? And there's this beautiful theater with a classic marquee, your name and lights kind of thing, and it's like a 700 seat theater. We sold it out fairly quickly, which I thought we would, because I've got a lot of fans in Iowa, a lot of people I know in Iowa, the whole eye department, a lot of the I still hear pretty regularly from people at Iowa who love that Dr. Glaucomflecken, it has an Iowa connection. All the rural medicine skits come from my experience at Iowa, so people relate through that. So I just got a lot of people that love the Glaucomflecken stuff in Iowa. And so that's why when we were planning this tour for our Wife and Death show, that was the first place like that was on the list. Like, we have to go to Iowa. We have to go to the Englert Theater. We have to do a show there for the wonderful people at the University of Iowa and surrounding communities. And we did. It was an awesome time. But then I started feeling bad because the show was on a Saturday night. And I started feeling bad. I was like, well, like the only seats 600 people. It sold out so fast. There's going to be a lot of people who either couldn't get tickets or they had to work on the weekend, because sometimes they forget. Yeah, people work on the weekend. It's a thing that healthcare does. And people get sick on the weekend. It happens, as much as my fellow ophthalmologists try to not think that it does. It does happen. And so I was like, I got in touch with the Alumni Association at the University of Iowa, the hospitals, and threw it out there that, hey, maybe I can just walk around the hospital for a couple hours on Sunday, surprise people, and just say hi and give people like a little bit of a happy, a tiny little dose of dopamine, a little morale boost to see a random ophthalmologist walking around the hospital. and so I did. I walked around. I had a wonderful psychiatrist and an OBGYN physician. The two of them, they took me all over the hospital. I got to see a lot of places that I hadn't seen since I left in 2017. And it was amazing how it wasn't like I recognized seeing the places. I recognized a lot of things by sight, but it was the smells, you guys. The smells, it's amazing. Like there's always, every hospital has that floor it's the medical floor, right? That just always smells like C. diff. I think that's what it is. It's just that hospital inpatient smell. I don't know what it is exactly, but it's a very distinctive thing. And as soon as I walked onto that floor, I was like, I know exactly where I am. Not going to say it's a pleasant smell, but it's just what it is. Lots of not so great things happen in a hospital, and those have smells associated with them. So, and what I would do is I'd go to all these different floors. We went to the general medical floor. We went to the burn unit. We went to neonatal unit, labor and delivery, psychiatry, all over the place. Except for obviously ophthalmology. No one was there. And even radiology, we just stopped by there. The emergency department, I went to go see the old eye room where I spent a lot of time in residency. And a lot of people were surprised. It was a lot of fun. Lots of pictures were taken. Chatted with all the residents who were working on the weekend. And it was really great. It was great. To be back there, even though it was a hospital, I didn't have to work. It didn't feel like work. I got to pose in front of some whiteboards where someone had done some teaching. There was a whiteboard that was like all about liver enzymes. I don't know. There's a picture of a liver. And I stood in front of it and furrowed my brow and stroked my chin and posed that way, just to let everyone know that, hey, I can think about this stuff too. Just because I'm an eye doctor doesn't mean I don't know something about it. Anyway, didn't go on rounds. That would be a little bit too much, I think. But I did, just walked around and saw people. They have a beautiful children's hospital overlooking the stadium at Iowa. Awesome. Just really, it was a great time. And sometimes going back to your old, where you trained or where you did depending on your experience, it may not be a good experience. You may not want to ever go back if you had a bad experience. But I had a wonderful experience. The people of Iowa during my time there from 2014 to 2014 to 2017, they treated me very well. And it was for the live show on Saturday. God, just awesome crowd. I knew it would be. Just so supportive. We've done some shows in bigger places, Southern California, places where they're used to getting shows. They're used to famous people. And I'm like on the lower end of like quote unquote famous people. Like they're getting real famous people that come through all the time, that host all kinds of shows, concerts, comedy. And I feel like big markets like LA, New York, they're just so used to it that it's not a big deal. And on this tour and some of the other places I've been, it's been so much fun going to like maybe the smaller places that don't get a lot of that. Places like Iowa City, Fargo, North Dakota, Kansas City. There's so many examples. Milwaukee, places like that. And they're just, those audiences, they're just different. They're energized. They're enthusiastic. I realized I mentioned a lot of Midwest there, and maybe that's part of it. People in the Midwest, they're just so nice and welcoming, and there's great hospitality. But anyway, I've grown to really appreciate. Raleigh was another one. Fantastic show at Raleigh. All the crowds are great. It's just, I feel like there's just this little extra bit of excitement when you're in a place that's a bit smaller, a bit more of a tight-knit community, and you're not used to seeing a show like this. You're not used to people going out of their way to go visit you. And so anyway, so if you're like a small to medium-sized market, like, and you have a big medical community there that has a lot of Glockenflecken fans, reach out to me, because I'd love to bring our show to you in some way. knocknockhi@human-content.com. We're always looking for great places to go. Earlier this year, I went to and did a show in Fargo, North Dakota. I did a show in Reading, Pennsylvania. Unbelievable. Like, sold out crowds, and people were in costumes. Like, I want to hear about those places. I want to go there. I want to go to where you are. And so anyway, just a wonderful time. So let's take a quick break. We'll be right back. All right. So another thing I wanted to talk about before we get into our case of the day, because we are going to talk about eyeball stuff, I promise. That's the point of this. Is I've realized I don't think I've mentioned on this podcast. Maybe I have. I can't remember. I can barely remember what I do yesterday. Is my partnership with the New England Journal of Medicine. We've now published the third video, just published today as of this recording, and I gotta say, I am having so much fun with this. So for those of you who don't know, first of all, I don't do a lot of like paid partnerships. I don't like having that kind of hold over my content. It's very rare. If I engage in a business partnership using my skits, using my characters, it's because it's something I really believe in, that I really think will actually improve patient care or improve the lives of people who work in healthcare. So like something that I believe in. That's my standard for engaging in a business partnership. And so the New England Journal, not too long ago, came to me and emailed me, and it was basically like, hey, we have an idea for trying to get more engagement among the next generation of physicians, because I guess a lot of journals are kind of struggling right now. So I was like, okay, well, what do you have in mind? And so they brought up this idea that they would give me a couple of the trials that they publish every month, and I would make a skit out of those trials. A skit like what I call a comedy abstract. Basically, it's abstract, but in comedy form, just a way of meeting people where they are. And number one, I was like, yes, this is awesome, because one of the things I love to do is try to trick people into learning things, right? I've done it about the healthcare system. Well, why not do it about actual like up-to-date research? And so I was like, it seemed like a challenge for me because, sometimes it's hard to explain complex ideas in like 90 seconds. But also I'm an ophthalmologist. And so all of these trials are outside of ophthalmology, right? And so I was like, oh, that sounds like a challenge. I can try to teach people about things outside my medical field. But I don't have to like come up with the actual knowledge. It's just given to me, and I have to figure out how to present it. So anyway, so I was like, this is great. I love this. Also, it's the New England Journal of Medicine. I've been very critical about publishers in the past and my content. And people have mentioned that to me after seeing me engage in a partnership with a publisher. But there's a reason I wanted to do this with the New England Journal, because the New England Journal of Medicine is a nonprofit publisher. It's published by the Massachusetts Medical Society. Not that nonprofits are without fault. That's obviously you can have bad things happen in nonprofits, but it's a far cry from the Elsevier's and the Springers of the world that have profit margins north of 20%, who rake in billions of dollars every year. This is very different. New England Journal is not that. And so I was like, yes, this is the right organization, the right project. Let's do it. And we've published 3 of them so far. And it's just so much fun. People are like, oh, this is, I want to learn about all trials through like these characters, which is probably not reasonable to like think that, but it's just fun to meet people where they are, try to change how education is done in certain ways. And I think that all credit really goes to the New England Journal of Medicine for having this idea and coming to me with it. And so check it out and I'd love to know what you guys think. If you like the, I published one. I'm not going to publish all of them on my channels. I give them the New England Journal. They can do what they want on their platforms. I did publish one on my other channel at D Glockenflecken, my YouTube channel, not this one, the other one. And so, yeah, I'd love to know what you guys think. I think it's fun. It's just a fun way to learn. So, okay. Now, enough about that. It's been like half this episode just talking about non-ophthalmology stuff. I know I can hear many of you just under your breath, just get to the eyeball stuff. Come on, buddy. This is not what I'm here for. I want to hear about the sclera, the episclera. Did you know the white part of your eye is the sclera? It's not the conjunctiva. A lot of people think conjunctiva is the white part. No, the conjunctiva is translucent. Did you know that? Yeah. It's the sclera is the white. That's where you get the white. It's this hard fibrous outer covering. See, like this model here. Here's an eyeball model. All right. This eye does not have any conjunctiva on it. No, this is all sclera. And the eye muscles are connected to the sclera. All right, you can see the eye muscles just come right off the. This is kind of actually what you would do. You would cut the muscle off when you're doing strabismus surgery, and then you resuture it to the sclera. So anyway, and whenever you have an open globe, you have a laceration of that white covering, that sclera, and you have to suture that back up. Those are harrowing surgeries. I haven't done one in a while. Part of the reason I like this job that I'm in right now is because there is not a lot of open globe injuries. What the hell? Why am I even talking about this? I don't know. Talking about sclera, white. Oh yeah, just you guys are probably wondering about that stuff. Anyway, so what we're going to do today, what I've decided to do is present a case that represents a disease in ophthalmology that I would least like to have. Some of the scarier things. I'm going to do one for each subspecialty in ophthalmology. Now, there's a lot of subspecialties in ophthalmology, right? There's cornea, there's glaucoma, neuroophthalmology, plastics, pediatrics, retina, and the vitreous. You can throw like uveitis in there, tumors, systemic disorders like syphilis or something like that. Also trauma, cataract. There's lots of different little segments in ophthalmology. So what I thought I'd do is just choose one from each of these little segments of a disease that I would least like to have. We'll call this like worst case scenario eye problems. All right. So these just, and this is kind of like, part of this is just personal preference. Like I've treated these diseases, I've seen these diseases, I know what can happen, and so they scare the hell out of me. All right, diseases that scare the hell out of me as an ophthalmologist. I got to workshop a term for this type of series, so obviously, because I've thrown like 3 or 4 different options. So we're gonna start with cornea. That's the front of the eye. Let's start there. And so I was thinking about, like, what are my options here? Like, what would I really, really not want to have as an ophthalmologist? What disease would be difficult, terrible? I thought about like certain diseases like, like keratoconus or Fuchs dystrophy. There's pretty good treatments for those. So those didn't really, get anywhere close to making the list. There is, certain congenital issues that can be kind of tough. But then in those situations, yeah, those are bad, like congenital aniridia. There's, we've talked about ocular albinism. But it's kind of like you're born with it and you don't know what good vision is. And so they're terrible diseases, but I've had patients with those diseases that can adapt amazingly to them, and can still lead like wonderful, very fulfilling, enriched lives with some of the accommodations that we have. That's what I'm trying to say. And then there's infectious diseases. All right, like gonorrhea, chlamydia, and herpes. That's another one. But all of those are pretty straightforward in terms of treatment, and you can make a full recovery. And really, for me, it came down to 2 things. Chemical injuries, all right? A bad chemical injury with like a basic compound like lye or sodium hydroxide, that's really bad. The other thing would be Acanthamoeba. That's my choice for Dr. Glaucomflecken's worst case scenario eyeball thing for the cornea. I would not like to have Acanthamoeba keratitis. All right, let's talk about what this disease is. So Acanthamoeba, I'm just going to talk about the pathogen first. So Acanthamoeba is this ubiquitous pathogenic protozoa. It's a protozoa. What exactly is a protozoa? I don't know, but it sucks. It's terrible. It's an organism that exists in a couple different states, right? You can have the active form where they're moving around. There's double-walled cysts. That's what they call them. That's the dormant form. The active form is they have little flagella. They're moving around. They're active. They're replicating. They're causing problems. And then you have the dormant form of this protozoa, which is the double-walled cysts. So if the Acanthamoeba is under duress, the organism converts from that mobile form to a more durable cyst form, making it highly resistant to killing it. You can't freeze it. You can't irradiate it. You can't chlorinate it. It's why even in swimming pools, hot tubs, public water supplies, you can still have Acanthamoeba, which is how a lot of people end up with this. And so that's why hot tubs scare me. All right, hot tubs scare me, but also particularly wearing contacts while being in a hot tub, or wearing contacts in the pool, or even contacts while showering. So this infection was first recognized in the 70s in contact lens wearers. In the 70s, I would say that's when there started to be a lot more contact lens wearers. The technology started getting a lot better. And so we got a lot of people wearing contacts, and we started recognizing this disease about a decade later in the 80s. And it was hypothesized, which is still pretty much the hypothesis today, that corneal microtrauma, little cuts in the cornea, induced by contact lens wear, because you think about it, you're kind of causing little abrasions when you're putting in the contact, taking out the contact, accidentally scratching your eye a little bit. You get a little foreign body sensation. All right, that's probably that little bit of microtrauma. And when you're damaging the eye, even to such a small extent like that, you can provide a pathway for these Acanthamoeba cysts to get into the cornea. Bad news. Bad news. And in healthy individuals, it really is localized to the cornea. In immunosuppressed patients, they can get encephalitis from Acanthamoeba, this chronic granulomatous encephalitis. They can get it in their skin, cutaneous amoebiasis. It can cause more of a systemic disease. But for us, for our purposes today, we're talking about healthy individuals that end up with Acanthamoeba keratitis. All right, let's take one more break, and then we're going to get to how these patients present, how you diagnose it, how you treat it, and what happens after that. Okay, here we go. So, presentation of Acanthamoeba keratitis. And the reason part of the reason I know so much about this is because we saw Acanthamoeba keratitis all the time at Iowa. I don't really know why. And in fact, I'm not sure if anybody knows why. But for some reason, and part of it might be just we had a very well-known cornea department with some really smart, brilliant faculty members. And there was a huge catchment area for Iowa. And so we just get a lot of patients that come in. If you have an eye problem, a lot of people just go to the university. This is a weird thing. We don't normally see this. Acanthamoeba is not really that common, but it's, for some reason, very common in the Midwest. All right, so patients will come in with pain. Often pain that's out of proportion to their clinical exam. You may look at that cornea. They may even stain the cornea, like put the little fluorescein dye on there, and you don't really see much. Maybe the cornea in a couple spots looks a little hazy, but man, the eye is pretty quiet. There's not a lot of red, like conjunctival injection, but the patient is in fairly severe pain. And so it's kind of an interesting thing there. They can be very sensitive to light, and it can be a very slowly progressive, protracted clinical course. So this can gradually get worse and worse over the course of months. The patient is going to very often, most of the time, they're a contact lens wearer. And sometimes you can there's like an obvious source of the infection, like the patient's using homemade saline solution. Your don't do that eyeball tip of the week, by the way. Don't make your own saline solution to clean your contact lenses with. Don't do it, all right? I don't care who told you to do it on TikTok. Don't do it. I'm on TikTok. I'm telling you not to do it. Please trust me. I'm a board-certified ophthalmologist. Do not make your own contact lens solution. Just buy it, all right? Please. Saline works great, but don't make it at home. So homemade saline solution, use of a hot tub while wearing contact lenses. Please don't do that. Please just put on, I know it's annoying, but either don't use a hot tub or just wear glasses or just be blind in a hot tub. It's a small tub. You're not going to hurt yourself. Hopefully. Or like if you're swimming in like lakes or, tepid water or contaminated water. But usually it's just contact lens wear. Sometimes that's all you have going for you in terms of history. And so on examination, so we look at the patient, and like I mentioned, sometimes you don't see a whole lot. Sometimes you can see what is a circular, what we call a ring infiltrate. So that's when as the infection starts to progress, that is how it'll form. It'll form this little ring, this little white ring in the cornea. You can look up, just Google this, and you'll see ring infiltrate acanthamoeba. That's after it's gone pretty far, okay? And the reason it's so painful is because you get this thing called radial perineuritis. All right, so this acanthamoeba, it tracks along the corneal nerves and causes all this pain. As the infection progresses, it can cause corneal thinning and eventually perforation severe inflammation in the eye. I've seen patients that end up with penetrating keratoplasty, full thickness corneal transplants, to try to treat this, try to just cut out the infection by doing a transplant. That's a pretty intense treatment. It's like the last line of treatment there. So we'll talk about treatment here in a second. The way you diagnose this, though, mostly it's clinical. But if you have the means, if you're at a big, academic medical center, they're going to have something called confocal microscopy, where you can actually visualize the cyst. You can use a special technique to image very thin layers of the cornea and actually visualize the Acanthamoeba cysts that are sitting there inside the cornea. So treatment. What do? We have the diagnosis. What do we do about it? Unfortunately, there are as many treatment combinations as there are ways to diagnose it. All right. So there's a lot of different treatment options. The question is, what do you do? And all of them are not your typical treatment. You can use a medication called PHMB, polyhexamethylene biguanide, chlorhexidine, propamidine, which is Brolene, hexamidine. There's imidazole, triazole, antifungals, miconazole, ketoconazole, itraconazole, aminoglycosides, neomycin, all these things. There's all these different options. So it's and the hard thing is with Acanthamoeba, and part of the reason why I would not want to have it is because it takes a long time to treat. As I mentioned, when under duress, these mobile Acanthamoeba they enter into this cystic form, these double-walled cysts that are really hard to kill. And so it's not unusual for patients to be on treatment for 6 months, a year, to try to get rid of all of this. And you're using this confocal microscopy to monitor the treatment. And so you're sitting there, you do treatment for 3 months. They're on drops every 2 hours for 6 months. And then you come back, you look at the confocal microscopy, you see if you can find any cysts. Oh, there's a cyst. Let's put you on treatment for another 6 months. It's hard. It is hard treatment to clear this infection. And then if you don't clear out every single cyst, every single bit of that Acanthamoeba, and you stop treatment too soon, what's going to happen? It's going to come right back. And as I already said, in impending perforation, or if there's a potential for, or if there's already a lot of scarring from this infection, because again, it's been there for months potentially, or even years, then sometimes you need to do a full thickness corneal transplant to try to get the vision back. So it is a scary, tough disease, not one that you can't treat though. So those of you listening, in the off chance that someone listening to this has Acanthamoeba, which, by the way, again, very rare, like 1 in 10,000, 1 in 100,000 rare. We don't really know the significance. It might be, or the incidence, it may be higher. So we don't really know, but it's not common, I should say. So I don't want people to despair thinking there's no treatment, because there is treatment. It's just a hard treatment. That's all. But if you have a good, dedicated ophthalmology department that's willing to help you through this, and there's a lot of them out there, look for the big medical centers. All right, shout out University of Iowa. I know they do a great job with it. I'm sure there's many, many others. There is hope for you. I just personally, speaking as Dr. Glockenflecken, board-certified ophthalmologist, during my day job, I really don't want it. I don't. I would do everything I can to avoid it. Which, again, this is what I'm going to leave you guys with. Again, how do you avoid something like this? Because you can take steps to prevent something like this from happening. All right? Don't just... Contact lenses and water, that's not your solution. That's not contact lens solution. It just doesn't mix. All right? you really shouldn't be doing any water activities, even showering. Now, that's probably the least terrible thing to do because at least you're not like sitting in water. You're not, but even that's not great because certainly tap water can have Acanthamoeba in it. So you can, I have seen it. You can get this from showering in your contacts. But tap water, fresh water, any kind of non-contact lens solution water and contacts do not mix. There's harmful things in water. So don't mix them, okay? Please. We don't want you to get this. But we'll help you through it if you do. That's it. That's my I mean, I realize now after recording this first one that this series might be very depressing. Maybe I'll try to do some like less scary ones, but that one seemed kind of scary to me. Maybe I'm just in a bit of a pessimistic mood right now, but I don't know. We'll see. But that was the first of the I Don't Want This series of Knock Knock Eye episodes. Again, this is the cornea. I'll choose a different part of the eye next week for our case of the day. So let me know what you thought of the episode. If you have any ideas, if you have any thoughts, if you have any questions, concerns, if you have any corrections for me, please let me know. knockknockhi@human-content.com. I always check I didn't do any YouTube comments today, but I always check the YouTube comments at Glockenfleckens. That's where you'll find video episodes of this podcast. Go and check those out. Leave your comments there. Even if you listen on like your favorite podcast listening app and then go over to YouTube and leave a comment there. That's okay. That's all right. Throw a like in there too. Maybe a follow, maybe a subscription. I don't know, whatever. Just subscribe. Subscription. I don't have subscriptions, but it is a subscribe. Anyway, we're really going off the rails here. Leave a comment. I'd love to hear what you thought. I love to address your comments too. Thanks to my producers, Aaron Corney, Rob Goldman, and Shanti Brick. Editor-engineers, Jason Perdizer. Our music is by Omer Benzvi. Thank you all for listening. We'll see you next time. Knock Knock Eye is a human content production.
Knock knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.